We sometimes see patients, generally younger patient, with complaint of chest pain and not getting relieved with proton pump inhibitors or antacids. And given the absence of risk factors for atherosclerotic cardiovascular disease, we don't even think that this may be myocardial ischemia, because patient is young, does not have risk factors for atherosclerosis. So we think that it might be psychogenic or might be musculoskeletal chest pain, but it can be myocardial ischemia as well. I have seen some such patients whom I tried antacids, proton pump inhibitors, even nitrate SOS. Despite her pain was not relieved, and I also tried then SSRI, serotonin reuptake inhibitor. It was not responding. So what do you think? Can it be myocardial ischemia? Yes, there is a term called microvascular angina. Before telling about microvascular angina, I would like to give you overview of blood supply of myocardium. Myocardium is about 300 gram tissue, and this is supplied by left coronary artery and right coronary artery. The thickness of myocardium is about 1 centimeter in left ventricle, and it is about half centimeter in right ventricle. I am not talking about atrial thickness, because it is just about 2 mm, and chance of ischemia is very less because the size is very thin. And why ischemia occurs in the myocardium? Because on the top of the myocardium these big arteries travel, right? And from those big arteries a smaller microvasculature penetrates the myocardium and goes deeper and supplies the endocardium. Right? So this is the basic anatomy. So when there is atherosclerotic occlusion, thrombotic occlusion of these epicardial coronary arteries, then that is serving big areas of the myocardium, and there is chance of damage to big area of myocardium. And if a large portion of myocardium is dead, the consequence. It will go to heart failure, left ventricular failure. It is involving left ventricle. But those small vessels, small arteries that are penetrating the myocardium from the bigger arteries, those can display dysfunction. The endothelium lining the small arteries can undergo endothelial dysfunction due to certain triggers like even viral illness. What I mean by endothelial dysfunction is that when there is need of blood to the myocardial fibers, then those vessels should dilate. But when there is dysfunction, that is not able to dilate. and if it is not able to dilate, then the myocardial fibers will suffer ischemia. We now know this phenomenon because this is well studied. But previously, more than a decade ago, when they have not done this research on this topic, they used to call it syndrome X, because it was not known what is this phenomenon. But we now know it, both theoretically and with good amount of data. That's why we label it microvascular angina. So the problem is endothelial dysfunction. The diagnostic part is confusing. You have to highly rely on clinical history, because even ECG is not sensitive to pick up those. ECG detects changes when big amount of myocardium is not able to conduct electricity properly, but when there is a small arteries not able to provide enough oxygen, and that occurs episodically, ECG is not sensitive. Even if you do ECG, you might not see any ischemic changes. Leave about troponin. I told you that weight of myocardium is about 300 gram, and when like 20 gram, 30 gram myocardial tissue is damaged, then only sufficient troponin is released in the bloodstream to be detectable from the peripheral blood. So troponin get diluted in this 5 liter blood that is in the circulation. So troponin is also negative in those small microvascular dysfunction. Even there is infarct, a small microvascular infarct that is not able to detect sufficient troponin so that we can detect in our lab. So ECG is also negative, biomarkers is negative. Even if you do angiography, either CT angiography, percutaneous angiography, those are negative, because you cannot delineate those microvessels. In angiography, they are only able to detect some branches of epicardial coronary artery. They are not able to detect deeper arteries. So those are not useful. So we have to heavily rely on our clinical acumen for diagnosis of microvascular angina. This is a smaller part of vasospastic angina. Why I am telling it a smaller part? Because in vasospastic angina, this big epicardial coronary artery undergoes endothelial dysfunction and can periodically undergo vasospasm. And when it is big arteries, then it responds to nitrates. If you tell patient to take nitrate when you have such episodic chest pain, then if it gets relieved, then it suggests it can be vasospastic angina. But in microvascular endothelial dysfunction, even nitrates may not be responsive. Patient may not feel relief with nitrates. So what is the treatment of microvascular angina? Main thing is lifestyle modification, like if overweight, try to lose weight. Smoking, if patient is a smoker, abstain from smoking. If diabetes, hyperlipidemia, manage those with medications. And regarding cardiac specific medications, we have calcium channel blockers, we have beta blockers. We can try calcium channel blockers or beta blockers. If it does not help, then we can try ranolazine, ivabradine.